think it's amazing what they can do nowadays with this 3D imaging.
I've been given my tongue because of this operation, and it has saved my life.
We wouldn't have been able to do this 5 years ago accurately and get the sort of result that we're looking for.
This programme looks at the revolutionary impact of three-dimensional imaging in transforming surgery. Norma was a victim of the Omagh bombing in Northern Ireland. She was 28. She lost an eye and part of her face was destroyed. 3D imaging has played a vital role in rebuilding her face.
I remember it being a nice, busy, normal Saturday afternoon. Everybody was in getting their shopping. We got word to say that we had to be evacuated out. And we thought we'd stand in the middle of the road because we didn't want to stand close to the shops, because we thought if there is a bomb, if the bomb goes off, the glass will shatter around us. And little did we know we were standing right beside the car. The car exploded and that was it.
It was about early evening time that I would have received the first phone call from the Royal with regard to a patient, one of a number who had been helicoptered in from the site with very bad facial injuries. When I was asked to see Norma, she was anaesthetised at this stage. My ophthalmic surgery colleagues had already removed her eye on the left-hand side, and the shrapnel which had entered the left-hand side of her face, shattering her cheekbone, but leaving a sizable portion which was free-floating. What I was confronted with at that stage was the demand to reconstitute that as best we can under the circumstances, with the proviso that she was going to have further surgery to augment and improve the cosmetic result.
Peter Ramsey-Baggs, who took over Norma's case, has used 3D imaging to gradually reconstruct her face. He and colleague John Winder are finalising the 3D model to be used in her next operation.
Hi Peter, well, we managed to transfer the data of both Norma's scans across. We've got them on the computer now. Thought we'd go through them together. Okay. So this is a 3D surface shaded representation of her CT scans.
So this is basically the skin we're looking at here.
We're looking at the skin at the moment.
So it takes that information, which is originally from a CT scan,
yeah,
and turns it into essentially an engineering model.
Yeah,
which
that's
is,
exactly.
Yeah. So this is what we're actually going to have in our hands. This is the model that you will make. This is the CT scan here, and here is where the second operation was done to rebuild her orbital rim, bottom part of her eye socket. We've done that already. Now we're going to go back and replace the missing strata bone, which goes across here. Okay. If we can just see the other side, we can see what we're actually going to be replacing. This piece of bone here is what's missing. The shrapnel, when it went through, completely destroyed this, and we need to replace that to give her a contour of her cheekbone. So when I look at that, I just realise how far we've come in the last 3 or 4 years since we developed this, because this has been a real change in the way we can do things. With complex deformity like this, it enables us to diagnose the condition much more accurately, rather than looking at X-rays, which are, even if they're made to look like three-dimensional things, they're actually a two-dimensional picture. And you know yourself, seeing a photograph of somebody is very different to seeing the person themselves. So it enables us to make the diagnosis, work out where the defect is, work out where the bones are missing, where they've moved to. We wouldn't have been able to do this 5 years ago accurately and get the sort of result that we're looking for and expecting here.
In total, I've had 7 operations. The first one, of course, was the main one, which was the eye, the jaw, the nose and the ear. And then a week later, the rest of my body was done. And then about a year later, the surgeons then worked again on my eye plus my jaw. And I then had 3 more operations on the eye. And now this one will be my final, hopefully. On Friday, they're going to take a bit of bone work from my hip and they will put it into the side of my face, just here. So hopefully everything will go well. Oh, I think it's amazing what they can do nowadays with this 3D imaging, how great they can work, how they can rebuild somebody. It is just amazing. I feel that if they can bring me back my life as such, it is just worth going through with it. This operation means getting my life back, being normal again, going out and doing the things that I used to do without thinking anybody's looking at me anymore.
Dr. Alf Linney was one of a team of pioneering medical physicists in the early 1980s who developed the use of 3D computer imaging in facial surgery.
In the late 70s, we were exploring better methods for planning facial surgery. A lot of the planning was done in 2 dimensions. It was done on photographs and 2-dimensional X-rays. The head is a 3D object, obviously, and if you try to plan with 2D images of it, the results are likely to be unsatisfactory. You could make plaster casts, for example, but you could not represent very well the internal anatomy of the head. And at that time, 3D graphics had arrived on the scene. What we did was to develop a system, first of all, for scanning the face. So we had, on the one hand, data for the external anatomy. We also started to collect data with the modern medical scanners for the internal anatomy. To display it was the next question, and in particular, we wanted to simulate surgery if we could and predict what the outcome would be. And for that, I worked for a while with Chris Biscoe from the Slade School of Art. Once we provided data on the human face to him, he was able to display virtual patients on the computer screen, fully in 3 dimensions. If you can visualize it in 3 dimensions, then you can rehearse the surgery in a realistic fashion.
Up until a year ago, Michael was working as a carpenter in North London. He was diagnosed with aggressive cancer. Michael's had 3 major operations to his tongue and neck. These have left him unable to talk or swallow. He has to feed himself intravenously. And the cancer has come back. Michael cannot have further surgery or radiotherapy for his recurring cancer, but he's being offered a revolutionary new treatment, photodynamic therapy, unique to University College London hospitals. PDT, as it's called, is heavily reliant on the latest developments in 3D imaging techniques and is seen as a promising breakthrough in cancer treatment.
I would hope that with Michael we'll be able to keep his quality of life at a satisfactory level so that he doesn't have further problems with speech and swallowing, that we will be able to reduce the bulk of his tumour so that we're able to control his pain. I'm very hopeful that we will be able to improve things from that point of view. What we're going to do today is we're going to give you an injection into a vein in your arm of a drug that will make you quite sensitive to light. We then wait for a couple of days for that to get distributed around your body. It's concentrated in these cells in this abnormal tissue in your neck, in this tumour that you've got in the neck. So when it reaches the maximum concentration that we want in the tumour, then by shining light at this, we cause a reaction that kills the abnormal cells.
Right, you. Now I'm going to give this the Foscan into your vein. Now you'll feel this sting. I'll be injecting it slowly anyway, just to reduce the discomfort for you. There we go. Need to do this over 6 minutes. I'm going to watch it.
The drug makes Michael ultra-sensitive to all light, so he must protect himself from it until the treatment. Back in Northern Ireland, the eve of Norma's 8th and final operation has arrived.
Oh, tomorrow morning I'll probably feel, has arrived. It's the final day is here.
This is it now?
Yes, it'll be good to get it all over with.
Getting the other side of it? And
Yes.
forward
Actually closed the book completely. From start to finish. Sort of thought I would never see this day.
This is Norma's model that we had made by the engineering department from the 3D imaging that you saw with Mr. Winder. And as you can see, it's just a little bit different to seeing it on the screen to actually holding it in your hands and be able to turn it around. You can see that this eye socket here is a lot smaller than the eye socket on this side, and that's because this cheekbone here was pushed back and downwards and partly destroyed, and the cheekbone on this area here is completely missing the little arch of the cheekbone. About 2 years ago, we were able to reconstruct this part of the orbit, the eye socket, and we used this template then to get our bone grafts and to make the sockets the same size. And you can see that they are now the same size, and unfortunately Norma has to wear a glass eye, but it sits well in that socket. Today's operation is to replace the missing arch of the cheekbone. When we look at this side here, you can see there's normally a strut of bone there which gives the face its natural prominence, and in Norma that's missing and this is all flat. And this is what we plan to use. This is the template we've made for today, and it fits across there. And what we'll do is expose this area surgically, and then we can put the onlay on to make sure it's in the right place and the right fit. Then we'll take some bone from the hip, and using this we'll carve the bone from the hip to the right shape, and then we will fix the bone graft in place there with some small metal plates and screws, and then close up again. And that's today's plan.
A lot to do. I think actually what's frightening me the most is the way they're actually going to operate. You know, cutting me open and pulling down through my hairline, putting bone work in. But hopefully it'll be okay.
After 4 days, Michael returns for his PDT treatment.
This is really just the tip of the iceberg, this tumour that we can see here. So what we need to do is image it in the MR scanner, and then we'll treat all of the tumour that we see.
World pioneer Colin Hopper works closely with senior radiologist colleagues who are preparing the laser fibres, which will deliver the light to Michael's tumour.
The ability to see the treatment in real time and actually understand in three-dimensional terms where the tumour is and ensure that we deliver light to all of that tumour is the most exciting thing yet.
These are the planning scans that have been done. Here's the ulcer immediately behind the point of the chin, and here's the one slightly to the side on the right side. And the slightly lighter grey areas correspond to the tumour.
Hey. Now these needles that we use in this are special titanium needles. They've got to be titanium or else they fly around in the magnet, and that can get rather exciting. So the titanium ones are non-magnetic, and the idea is that we're going to position them using this grid, this snooker rack grid in the right distribution. Okay. So, Joe, the treatment we've been developing here is to actually deliver the light deep into the tissues of the head and neck. We're doing that without doing an operation to get access to the tumour, but we're actually getting our light delivered into the tumour tissue directly by using needles that we pass through the skin into the target tissue itself. It requires quite sophisticated imaging techniques in order to ensure that the needles are in exactly the right position. And it's this combination of technologies that is virtually unique to this establishment. And they all go down to the same level. Okay. So there we are, they're in position. Now we're going to take a check scan to make sure that we're clear of everything vital, and then we'll do some treatment.
This was our planning scan, and now we can see the position of our needles that have been placed. There's the third needle, and there's the fourth. They could all go just a tiny bit further.
So we need to advance them by about half, 1 centimetre?
Another half to 1 centimetre.
Okay. One of the things that you will notice when we're treating is the extent to which this part of the face will glow. There is a huge amount of light being delivered into here. Now, when light falls upon a cancer that's been sensitised with the drug, there is a reaction between the drug and the light in the presence of oxygen that causes cell death.
Cancerous cells absorb more of the photosensitizing drug than ordinary cells. So when laser light is directed deep into the heart of the tumour, where the drug has accumulated, the cancerous cells are destroyed.
It causes cell death without any heating. It's very important to understand that it's a cold photochemical effect. And that means that there's no damage to the surrounding supporting structures of the body, such as the collagen and the elastin, so that we get healing with very little scarring. PDT is repeatable, and if patients, as they often do, go on to get further cancers in their mouth or the head and neck, you can go back and retreat them any number of times.
Tommy is a PDT success story. 5 years ago, he was told he had a cancerous tumour on his tongue. Despite months of chemotherapy and radiotherapy treatment, the tumour returned.
When I went back to the maxillofacial clinic, the talk was of having my tongue, virtually 90% of it taken out, which was, I just could not face that. And I asked, was there any other treatment? And there was this revolutionary new treatment, laser treatment, which I opted for. I've been given my tongue because of this operation, and it has saved my life. And I just feel so happy inside. I thank God that I've had this treatment.
In theory, the potential for this treatment is to do anything that you can do surgically, and to some extent with radiotherapy. Any local treatment that we currently carry out by cutting tumours out could just as easily be carried out with photodynamic therapy. We can not only treat in short periods of time, but we can also kill fairly large tumours. So we're not just looking at very early cancers, we can actually tackle bigger tumours.
3D imaging was first used to help surgery to the head and neck, but it's now used widely for surgery to other parts of the body. Bernard, aged 77, had never had a day's illness until he suddenly collapsed, soon after retiring to London. He's about to have keyhole surgery for a potentially fatal aneurysm in his stomach.
The leg just gave way and I thought there can't be something wrong here, and I thought I can't walk no further. So I leaned up against a wall in Euston Station and I couldn't move from there. The leg was dead white and the foot was like, how can I say, a cube of ice. You feel that bottom, that foot, one was red hot, you feel that one, it's a cube of ice.
We just didn't know what was happening, did we? And if that weren't for the help we got, I don't know what we would have done. It just helped us.
Right, so here's the aneurysm. Well, aneurysm comes from the Greek word, which means dilatation. And if we take the aorta, this is a thick, muscular tube which has this vital function to perform, which is to allow blood which is pumped from the heart to go right through the body to all the various organs, everything from the brain, the eyes, down to the bowel. And the part particularly between the kidney arteries and where the aorta divides within the pelvis is rather prone to become aneurysmal. The wall degenerates, it becomes thinned, and it blows out rather like a balloon. And the bigger it gets, the weaker it gets, until finally it reaches a critical point and then goes bang. And when it goes bang, that's the end. The patient will die. Hi, Tony. Have you got Bernard King, please?
Mr. Adesanya and his team have created a 3D computer model of Bernard's aneurysm, providing them with its exact dimensions and position in the body, essential information to carry out the keyhole surgery successfully.
I know that you told me it was 9 centimeters with the clot, which isn't shown here. This morning, we're going to perform an endoluminal or an endovascular repair of Bernard's abdominal aortic aneurysm. So this is the main device, and you can see it's nicely compacted into this tube. And we insert that into the patient through the femoral arteries, which we use like the underground system. And once we get to the aneurysm, we push it out a bit like an umbrella, and it opens and unfurls in the place of interest. Right, this is Bernard's lower abdomen, and here is the right femoral artery and the left. And that's all the surgery he needs. There's no need to do any more exposure. So 2 incisions about 3 to 4 inches long in each groin. Right, now what we're going to do is, here's the device, and we're going to actually introduce it into the femoral artery.
It will travel up the femoral artery to Bernard's aorta, the site of his aneurysm. Once it unfurls, it reduces the flow of blood to the aneurysm and eventually allows the swelling to shrink.
Screen a little lower.
Watch, keep following. Now you see the balloon come down. Okay, it's coming right down. Right, come, follow me down, please, guys. Right, follow. Operation is virtually finished, and now the incisions in the arteries have actually been closed up. We're now going to do completion angiography to check that the stent's all right, and then we close the wounds, and that's the end of the case.
Bernard, hello there.
Hi, Bernard.
How are you?
How are you feeling now?
Very
It's all
well, thank
over.
you. Very well.
Yeah.
No one better here.
The traditional procedure was an open operation where the abdomen is open right from the chest all the way down to the pubis. They would need some time on the intensive care unit and probably a week, maybe 10 days in hospital, and then a 3-month convalescence at home. With the keyhole type of procedure, it is possible for the patient not to require intensive care treatment.
After 5 days in hospital, Bernard is making a good recovery at home.
Now I sort of walk between 2 and 2.5 miles. I got a feeling that could be come to my limit. But physically and mentally, I feel as good as I did before the accident.
It's the day of Norma's last operation to rebuild her cheekbone.
Sarah, your head's going up. No, it began to do it. We're just shaving the head here because we're going to be making an incision across the top, around where we shaved, so we can turn this part of the forehead forward so we can get access to this area here. We can't make an incision in front of the ear because there's a very large nerve that comes out from just in the middle of the ear here and runs into the face and gives all the movement. So if we cut down here, we would cut through that nerve and she would have a paralysed face.
Enjoy the hypotension like that.
Yeah, well, I hope it's not going to be, we won't need it forever. Now.
The 3D model is referred to constantly throughout the operation to ensure accuracy. Mr. Ramsay Baggs is about to take bone from Norma's hip and fashion it into the shape of her missing cheekbone.
Oh, a lovely piece of bone.
Okay, just keep that well.
Oh, it's all right, isn't it? It's a little bit short, but we've got plenty here to bulk it up with here. The bit of bone is reasonably good shape. It's not as long as we'd like it to have been, so we're going to have to take some off the top and add it to the end, but we were planning to do something like that because if you see the three-dimensional shape of the bone here compared to the sort of one-dimensional shape of this, we were going to have to add a bit on the bottom anyway. So it's not a major problem, and we'll shape it all with a small plate.
The template allows Mr. Ramsay Baggs to fashion precisely the bone fragment to the required shape, so it can be slotted into the correct position.
So it's starting to come to the shape we want here. And we're going to have to build the depth up here with this because that otherwise it will be too far in. when we hold it above like that. Yep. Feel that bit. And that fits quite nicely into there. Suction, please. She's just got a little bit of a dent here. We've got a good prominence there, so we're going to just lay a little bit more bone on the top and iron out any small defects at the end. Before, it would have been a guess. We'd have opened the area up, we wouldn't have known exactly what we were going to be looking for, and ultimately the result wouldn't have been as good. Norma had no cheekbone on the left side here, and her face was quite flat on that side. And what we have done is to replace the cheekbone here, and what we hope we'll see is that on each side the cheekbones will now be level, and she'll have the normal facial prominences on both sides. And from what we can see so far, we seem to have achieved what we set out to do.
3D imaging has great potential. One can create really virtual people. To be able to explore the human body, for example, to trace blood vessels, to actually move along blood vessels and look around on the inside of blood vessels. That's very interesting to be able to see from that perspective. It's something you could really never see using any other technique.
This operation means getting my life back.
Physically and mentally, I feel as good as I did before the accident.
It has saved my life, and I just feel so happy inside.
Thought I would never see this day, but it has finally arrived.